You're listening to the EHA Hematology Podcast, Episode 2, Graft-versus-Host Disease. Welcome back to this second episode of EHA's Hematology Podcast. This is the podcast where you can listen to passionate experts in hematology talking freely about highlights in their fields of expertise. Today's episode speaker is transplantation expert Professor Shaun McCann. Well, Shaun, the mic is yours.
Hello, my name is Shaun McCann. I'm a retired hematologist, and I carried out the first, as it was then, bone marrow transplant in Ireland in 1984, and I was director of the National Transplant Centre for 25 years after that. So I have a little experience in transplant. I'm going to talk to you today for about 15 minutes about a syndrome called Graft-versus-Host disease, which is probably the most feared complication of hemopoietic cell transplant, or HSCT as I'll call it, both to the doctor and to the recipient. And I am going to start off with a little story. And the story is about the word serendipity, which I'm sure you've all heard of. Well, this word serendipity was first coined by a man called Horace Walpole in 1754, a long time ago, when he wrote a fairy tale about the princes of Serendip, and they kept making discoveries when they weren't looking for anything. So we use the word serendipity when we're looking very hard to find something, and something untoward happens, and that happens to be very important. Whereas chance, at least to me, means you're walking down the street and you stand on a €100 note and you put it in your pocket and run away. That to me is chance. So the two things are quite different, although often used interdependently. In medicine, I hope you will all have heard in our medical schools of probably the most famous serendipitous discovery, and that was by Alexander Fleming and the discovery of penicillin, which of course changed the world forever. So what's all that got to do with graft-versus-host disease? Well, there was a laboratory scientist called Delta Uphoff working with a scientist called Egon Lorenz in 1952 on an animal model, using mice primarily, of HCT. And what they would usually do would be to keep the mice in a cage following transplant for 14 days. Now, that wasn't really it for any profound scientific reason. It was for financial reasons, because keeping animals, as anybody who's worked in an animal laboratory will know, is quite an expensive business. So the animals were usually sacrificed at day 14. However, serendipitously, a cage of animals was misplaced and wasn't found for a further 2 weeks. So that meant the animals had been transplanted 4 weeks ago. And to Delta's amazement, the mice had diarrhea, terrible thought, inflamed foot pads, and their fur on the mouse's fur, as one of my friends said, it was called ratty. No pun intended, but it was rather strange looking. So the animals looked extremely sick, and nobody really knew what was going on. And this phenomenon or disease or whatever it was called runt disease, or secondary disease. Secondary to what, I'm not quite sure, but I presume secondary to the HCT. About 10 years later, Barnes and Loughton in the UK, and a few years later again, a man called Morton Simonson gave the name to this phenomenon, graft-versus-host disease, as they unraveled that it was due to an attack by the cells in the donated marrow, as it was then, on the recipient. And that terminology is still used today. Now, in humans, graft-versus-host disease following the classic, what we call myeloablative conditioning, is often, or was often, divided up into acute and chronic graft-versus-host disease. Acute occurring in the first 100 days following transplant, and chronic being graft-versus-host disease, which occurred later than that. We do know with certainty that the greater the degree of HLA disparity between the donor and the host increases the risk significantly of severe and lethal graft-versus-host disease. However, it also has to be remembered that even using a family fully matched sibling donor, graft-versus-host disease can occur in about 20% of individuals. Now, how does it manifest itself in humans? Well, the syndrome manifests itself by involvement of the skin, the gastrointestinal tract, and the liver, resulting in a skin rash, diarrhea, and jaundice in that order, usually, but not always. In terms of making a diagnosis, it's very important to do a skin biopsy, as there are many causes of a skin rash following HSCT, most notably probably antibiotic-induced skin rashes. So the diagnosis of acute graft-versus-host disease is difficult because attempts were made to stage the disease, that is, the number of organs involved, and also to grade the disease versus the pathological changes in the biopsy. Unfortunately, clinically, these don't always coincide. For example, you can have a person with a skin rash who's actually clinically quite well, and the pathologist will grade the skin rash or grade the skin rash as being severe. So it makes it very difficult for a clinician. However, if we look at acute graft-versus-host disease in grades 0 to 4, by the number of organs involved, that is the skin, the gastrointestinal tract, or the liver, we find that the higher the grade, in other words, the more organs involved, the outcome tends to be poorer. Now, the treatment for graft-versus-host disease, I'd have to say, is by and large unsatisfactory and hasn't improved very much in the last 20 or 30 years. The mainstay of therapy is high doses of methylprednisolone given intravenously, 1 to 2 milligrams per kilogram. And really, since that's been around for many, many, many years now, we really haven't improved on that. And what I can say is that the response of the patient to high-dose steroids determines the outcome. Not a very profound statement, you might say, but if you don't respond to steroids, you go on to second-line therapy with other immunosuppressant agents. There is no real agreed strategy as to what is the best treatment in patients who fail methylprednisolone. My memory of graft-versus-host disease revolves around a patient of mine on Christmas Day, December 25th, a young woman with acute myeloid leukemia in first remission who had a fully matched sibling allo-HCT. She developed acute graft-versus-host disease and wanted to discharge herself from hospital to be with her children on Christmas Day. Not unreasonable. So I spent 4 or 5 hours trying to convince her to stay in hospital, as I knew if she went home, she'd probably die. Happily, I was successful, and now, many, many years later, she's alive and well and free of disease. So it sometimes does involve quite a lot of interaction between the physician, the nurses, and the recipient. Now, have things changed recently? Well, perhaps our understanding is a little bit better, if not our therapy. The 2 people who I look to are Professor James Ferrara in New York and Professor Joe Anton, because they said many years ago that there were 3 steps in the evolution of graft-versus-host disease. One was the conditioning therapy, as I said, myeloablative conditioning, tends to produce more severe graft-versus-host disease. Activation of donor T cells, which we now call Treg cells, and the production of a so-called cytokine storm, followed by tissue destruction. The problem is that the T cells, which are involved in graft-versus-host disease, are also involved in the so-called anti-tumor effect or anti-leukemia effect of HCT. Now, to get around this, of course, a simple answer would be, why don't you remove all the T cells from the graft? So we did this, and we weren't the first to do it, but other people did it. And hey, presto, patients were very well and didn't get graft-versus-host disease. However, within 1 year, their leukemia came back. So the price we paid was huge. So obviously removing the T cells is not the correct answer. The correct answer has to be to find out which particular subtype of T cells is involved and try to abrogate them or remove them in some way. Now, the other problem, and I spoke to Professor Ferrara, is that, to quote him, you can't always translate the data from laboratory animals into humans. Now, a very famous man called Dirk van Beckum, whom I'm sure you've heard of, many, many years ago, was able to demonstrate that you could transplant, again, laboratory mice across the HLA barrier, and they would not get graft-versus-host disease if they were looked after in a totally sterile environment. So there's obviously a connection, as yet unclear, between infection and the advent of graft-versus-host disease. We and many others tried giving larger doses of unabsorbable antibiotics in an effort to sterilize the gastrointestinal tract of our recipients. It was horrible. The patients hated it. They got diarrhea. It never worked. They refused to take it. It's been abandoned, I think, everywhere. And we, as James Ferrara said, we never intend to go back there again. Now, Ferrara and his colleague Joe Anton have done a lot of work on the gastrointestinal tract and the so-called microbiome, or the organisms that inhabit the gastrointestinal tract. And he thinks that rather than having the old-fashioned classification, grading and staging system, we would be better off to have a diagnosis depending upon biomarkers which may be found in the blood. In conclusion, graft-versus-host disease is still a major problem for recipients of HCT and for doctors and healthcare professionals looking after them. We still have not unraveled the specific subsets of T cells in the donor, which are important for graft-versus-host disease induction and for the graft-versus-leukemia effect. Hopefully, people like Professor Ferrara and Anton will come up with a new grading system based upon biomarkers, which might be more helpful than the classical grading and staging phenomenon. So there's a lot of work to be done, and good scientists hopefully will resolve this issue in my lifetime.
That was Professor Shaun McCann for episode 2 of EHA's Haematology podcast. For other topics, we highly recommend the rest of this podcast series. For now, thank you for listening. And hey, if you're passionate about haematology yourself, why not contact us and star in your own podcast episode? You can reach us at education@ehaweb.org. Goodbye.